How many people in this room have heard of Earlens? Okay, so a fair number of you don't know what Earlens is. And for us, we've been involved for the last, we've been involved for the last 3 years with this technology, 3 or 4 years actually. And it's certainly not for all of your mainstream patients, but there's a certain subset of patients where this may offer an additional benefit and you want to have it in your office. It is an expensive option. You know, what do hearing aids cost today? You can get over-the-counter hearing aids for $300, and this device costs up to $12,000. So there's a big variety. But depending on your individual patient population, we have a lot of patients in our practice that pay $7,000 for a hearing aid. And I can tell you, this is the next advantage that will really change the hearing perspective of your patient. So this is Earlens, and we've been involved for about 3 or 4 years. The device looks like a traditional hearing aid on the outside, and then this is something that is placed down the ear canal. It's not truly like a contact lens. A contact lens is on the eye, and if you know, you have to keep it lubricated for the lens to stay in shape. This lays on the ear canal, and in order for it to be in the ear canal, you have to oil it. And there's a small little plunger that, I hope the video works. It's a advertisement, so you're going to see some advertisement kinds of things, but it's kind of a cool, this device, it's an electromagnetic device. So the tip of the ear lens is a little bit like sending a magnetic signal. You know, traditional hearing aids send an acoustic signal, but this is a magnetic signal, and the lens fits on the ear canal with a little plunger that touches up against the eardrum. So then electromagnetically it is stimulated, and it causes vibrations of the tympanic membrane. And for whatever reason, and I can't tell you the physics of it, I can just tell you that the eardrum moving because of something plunger effect on the umbo, it just hears better than people that have an acoustic stimulation. And we have plenty of studies that kind of show this. And then you have some external control signals that you can use. So as Selena kind of described, everybody's on alert. Patients come in today, they're worried about mom who has dementia. They want to decrease their chances of having dementia. So this is all a hot topic today. So hearing loss is at the forefront. There's some things by the Academy of Audiology that we actually have in our office, and there's 2 sheets. One talks about cognitive decline, and one talks about dementia. And that's on everybody's tongues today, so they're all interested in some type of hearing improvement. So that's something we hand out to all of our patients with hearing loss. And, you know, why do we have cognitive decline? Well, when you remember your anatomy, cognition is from the temporal lobe. So your acoustic center, and I have a map of this kind of in the office. In every office we have a diagram, kind of like that first one I have for dizziness. I have one for hearing. And it shows where auditory cortex is at. And then right behind it is short-term memory cortex. So what I tell patients is just like if you're not using part of your body, you go through atrophy. So if your hearing goes through atrophy, the short-term memory area will go through atrophy. So it's kind of easy to get people interested in trying to do something. So if you talk to hearing aid patients, the number one problem that they talk about their traditional acoustic hearing aids is sound quality. So sound quality is very important to them. And the second most common thing is having discrimination in background sound. So there's plenty of evidence. There's several articles that have recently been talked about different types of hearing aids and their bandwidth and how hearing improvement kind of goes on. But the purpose of my talk today is to kind of show you that sound quality and background noise quality of hearing with that situation is important. And you talk to patients because, you know, your practice is no different than my practice. I see more hearing loss, but trying to convince somebody that it's worth more than a traditional hearing aid. You know, there are pre-programmed hearing aids that are pre-programmed for a high-frequency hearing loss, and you can sell those to patients for about $12,000 for two. So I have to go through this whole hearing discussion also. And because this is so expensive, we do have to select out a few patients who have this. But these are the three most significant changes that I can offer patients with an ear lens. And I personally never go to an ear lens first. I make them wear a traditional hearing aid for at least a month, and then we decide how to go into this other hearing technology. Sorry. So the only difference, they both take acoustic signals and they bring them down to some type of electric signal. And it's just how that processor, that amplifier works. One simply produces a recurrent kind of auditory signal. I'm trying to see the pointer. Okay, so the auditory signal is sent out from the traditional hearing aid. That will send out the frequency response. Having a transmitter, it still does the same thing. It takes an acoustic center, which is vibratory energy, and turns it to electrical energy, then selectively amplifies it, and then converts it back either to acoustic energy, and a hearing aid has a 2-millimeter diaphragm speaker in it, or you can vibrate the entire tympanic membrane, which is the hope of using ear lens. So this is the difference. If you look at the frequency response of traditional hearing aids, it's somehow very good from 500 hertz to about 6,000 hertz. And we have measurements using ear lens that it goes down to 125 hertz, which is more of a vibratory sensation, all the way up to about 8,000 to 10,000 hertz. So if you look and see what that really does, you have these speech frequencies, and you look at those consonant sounds, the F, S, T, H, those higher frequency sounds are way out at 6,000 to 8,000 hertz, and the low frequencies, d, are more around 250. And that's where the ear lens, we hope, can help. If you look at traditional hearing aid, of course this is a little bit of an advertisement, but when you look at it, you know, hearing aids, their consonant level, maybe it's a little bit here and a little bit more here, but there's still, from the hearing aid range, you don't get all the consonant sounds ideally. And with the ear lens, the frequency response is simply better and over a wider range. So you can see it goes down to 125, clearly up to 8,000 hertz. So the richness of sound is a lot better. And this is what you traditionally will see with a hearing aid gain. So I'm fortunate I live in a Metro Detroit. I don't need it. So when you look at traditional hearing aids, unfortunately I live in Detroit area where we have a lot of music performers and things like that. And their sound quality in the professional level, you know, whether it be academicians or lawyers or musicians, trying to hear everything as clearly as possible, the ear lens has fit a niche in our practice. We only have done about 100, but those are really patients that really enjoy the sound improvement. So first of all, you got to clean the ear, and there's some ears that you want to put it in, but you simply can't because the ear canal is too narrow. There's too much of a mastoid hump. You have to be able to visualize the entirety of the tympanic membrane, at least 70% of the tympanic membrane. After we visualize that, we have to make a mold. So this is, you know, the hearing aid industry, they do this kind of thing all the time, but they don't go all the way down to the eardrum. So through a speculum, we're injecting this material that will give me a shape of a medial ear canal wall and tympanic membrane, because you need that measurement before you can put the lens to fit each and every patient. So we fill this up like this, and this is going to sit there for about 8 minutes, and it will solidify, and then we sit the patient upright. I guess I have to wait till the video stops, but I'll stop it. And then I can advance it. Good. We sit the patient up, and now we use a pink mold material. So there are two different consistencies. So this material sets up in about 3 minutes. And then after that sets up, we remove the ear mold. And this is the end result. So this has to be made perfectly because you need this ledge. This is the umbo area. And then we send this mold to California where Rod Perkins' business is all at for Earlens. And they make a reverse mold that looks like this. So this cushion actually fits on the ear canal, and the only part that touches the eardrum is the plunger part. So as you get their vibrations, this plunger is moving the entirety of the tympanic membrane. So to place the ear lens, just like a contact lens that has to be very lubricated, we lubricate this by you have to clean out every speck of ceruminous debris, epithelial debris. So we'll use oil on a cotton tip, and we oil the tympanic membrane so that it's just kind of moist, the medial ear canal wall and the tympanic membrane. And then when you want to place the ear lens, you hold it from this tip. And you can see this is a good picture of what the ear lens actually looks like. That plunger is very, very delicate. So you have to be relatively cautious as you're putting it down. You want to have a long tooth nasal speculum that we use in the ear canal. And then that will rotate. You see it going in one direction, and then you rotate it inferiorly as you put it in, so that anterior part, this is the left ear, we put it in straight and then angle it down so that the plunger is on the area of the umbo. And then we kind of push it down a little bit further, and you'll see it kind of seat. Once you get it close, it just kind of seats into place. So you'll kind of see us. This was the whole process of just cleaning it and then placing it. And then there's a kind of like sound that comes out electromagnetically, so you know it's seated in the proper position. They hear this very melodious sound. And this is what it looks like in the ear canal. You'll see that with the oil, this paraffin material, this lens-like material just sits in the ear canal beautifully. And they have to make it perfectly for this to fit for each individual ear. And then patients have to oil that 3 to 5 times a week, depending on each individual. And during this study period, we see patients back every 3 months just because some people will develop a little bit of a ceruminous debris or some type of drainage. So we're suctioning excess earwax out and oiling it on a regular basis. Where does this fit in my practice? Just for those patients, like attorneys, like people that need their hearing acuity as good as possible, people with a high frequency hearing loss who are really missing a lot of consonant sounds. One of my partners wears it who has a hearing loss. You do know it's in, just like a contact lens, you know it's in, but you tend to forget it just because, it's just like a little extra weight there. So we sell close to 2,000 hearing aids every year, and we sell about 40 of these every year, something like that. So it's a niche product, but for the right patient, they'll really enjoy the hearing quality, and I highly recommend it. And I'll take any questions that you have. Yes, sir.
How long does the whole process work? And then in terms of billing, how
It's, so the process takes patients, I have them try a traditional hearing aid so they know what it's like, and if they just love it and they think that's a cat's meow, then we'll end it there. If we have those select patients that want better hearing improvement, I make a mold. It takes, 15 minutes for each ear because you have to clean the ear, then you make the mold, and it takes 11 minutes to set up on one side, 11 minutes for the other side. Send the mold, and we get the actual device back in 2 weeks. So after 2 weeks, I place the ear lens, and they have the external device, and then they try it out. They have 2 months of trial before they have to decide whether or not they like it. Like traditional hearing aids have 4 to 6 weeks. With the ear lens, they have 8 to 10 weeks to decide if they like it, and they get a near full refund if they don't like the hearing improvement with it. So the process takes a couple of weeks is all. And I can just tell you for those special patients where either they're interactive with the community. I have several teachers, college professors who have put this in because they can't hear their students when they're going back and forth. So for those special patients, we should all know about it and be able to offer something like this. Any other questions? Yes, sir.
So if they take the post-auricular part of the hearing aid off, like at night, how much hearing loss do the lenses cause?
Lenses don't really cause any hearing loss. Maybe a little fullness or something is there.
So they can still hear their alarm in the morning?
Oh,
and
no,
stuff.
no question, because it's just a tiny, it's a fraction of 1 millimeter that's touching the umbo. So most of that ear lens is just on the ear canal. It's not touching the eardrum at all. So it's kind of a misnomer. You think of an ear lens like a contact lens, and it doesn't. Just that little plunger. Any other questions? Thank you. Just a niche product, but it really helps certain people. Thank you.
Thank you, Dennis. So